It's 1 o'clock, and so I want to make sure that we don't waste any time in devoting this grand rounds to hearing from our invited experts. So it's my pleasure to get to introduce our speaker for Psychiatry Grand Rounds today, Dr. Andrew Francis. And if you don't know why his name sounds familiar to you, it's because you probably used the Bush-Francis Catatonia Rating Scale to evaluate catatonic patients, either in inpatient or outpatient, and he is the man whose name is attached to that scale. So let me just sort of give a brief bio about Dr. Francis. He completed his PhD at SUNY Stony Brook in New York, followed by postdoctoral research in neurobiology at Cornell University Medical School. He obtained an MD from the University of Buffalo, followed by a psychiatry residency at Johns Hopkins Hospital. He was the co-developer of the Bush-Francis Catatonia Rating Scale, which is the standard clinical and research tool to detect and quantify catatonic symptoms. He's a recognized authority on catatonia, neuroleptic malignant syndrome, ECT, and delirium. Dr. Francis is widely published in these areas and has presented at regional, national, and international medical conferences, as well as serving as an invited lecturer at many major academic medical centers. Currently, he is professor of psychiatry and associate director of residency education and director of neuromodulation services at the Penn State School of Medicine at Hershey Medical Center in Pennsylvania. And I just want to give a shout out to Dr. Megan Shedd, who's, she was the one who sort of gave us the idea to invite you, Andy. And I was like, of course, he's way too busy for us, but I reached out to you because Megan asked me to, and you graciously said yes on very short notice. So I just want to say thank you so much for presenting to us, and we're really looking forward to your talk.
Thank you so much. My pleasure to do so. I wish I could be there in person. I have been to New Mexico just once, and had a very nice short visit in Albuquerque, and also the Sandia Mountains and Santa Fe. Great trip, and including one of those cowboy ranches up near Santa Fe, which they bring the tourists to. It was great fun. I hope to come back someday in person. Let me see if I can successfully share my screen. And did I succeed in doing that?
Yes, yeah.
Oh, okay. So greetings from Pennsylvania. We're probably quite a bit more green than you, although the trees are changing. I should have a new picture here with the beautiful fall colors. So this is Penn State Hershey Medical Center, where I work, and where some of this work was done. Most of this work was done prior, however. No disclosures, and I'll be talking about off-label treatments for catatonia. There are no FDA-approved treatments for catatonia. There are FDA-approved treatments, but they're approved for other stuff. And I do have a website, very easy to remember, catatonia.org. And that has a lot of information. It also has some of the same videos and additional ones that I'm going to be showing today. So in the case of catatonia, just like generally speaking throughout psychiatry, we hearken back to the European psychiatrists of a former era. And in the case of catatonia, we go back to a predecessor of Kraepelin. This was Karl Kalbaum, who was an academic failure. He didn't make it in academia, and he ended up buying a hospital in Eastern Germany, where he was the superintendent for about 35 years. And while he was there, he wrote a monograph about some interesting patients that he'd seen, unusual patients, over the past 10 years or so. And there's about 25, 26 case histories beautifully written in this monograph. It was translated into English in 1973. And in that book, he describes these patients. Patient remains motionless without speaking, a rigid face, blank stare. It can be fully developed. These are sequential paragraphs, by the way, from the introduction. It can be fully developed or only partial. There's an impression conveyed of mental anguish or shock. The German name, I'm going to butcher the German here, Spannungserregung, tension, insanity. You'll see in the British literature, catatonia is sometimes referred to as tension, insanity. Tension, I'm told that word Spannung in German has double meaning, like in English, both motor and psychological tension. we only hear about that distress that most of them experience, but not all, when they recover and begin speaking. Tends to be persistent, although in some patients it can come and go, so it can fluctuate. And most importantly, for the latter part of today's talk, Kalbaum, who's writing in 1874, notes that catatonia, which he named, is associated with medical illness. And what he's calling here muscular disorders, we would now call them neurological disorders. Neurology wasn't very far advanced. Wernicke didn't publish until later in the 1870s, for example. So really the important things about catatonia, that its clinical features, it can be persistent, but it can wax and wane, and that it's associated with medical and neurological conditions, all described by Kalbaum. So I got involved 28 years ago in catatonia, inspired by a resident whose name was George Bush. He thought his troubles were over after first George Bush, president. This was inspired by a patient that Dr. Bush was a second-year resident, and we had a patient with catatonia who, whatever we were trying, we didn't know a lot about it, didn't get better. Max Fink, who's turning 100, by the way, in January, was active on the faculty at the time, told us that, well, ECT treats catatonia. So we eventually did ECT on this patient. She got a lot better, of course, as people with catatonia do. And Bush, the resident, approached me and Max Fink and said, look, this is so interesting. We didn't know a lot about it. It's so dramatic. I want to study this. And I told him, you can't study something unless you have a way to measure it. And the result was the catatonia rating scale that we published 26 years ago, I think now. And it was a two-paper set. One was the development and characteristics of the rating scale, including the psychometric properties. And the second was what we learned about treatment using this rating scale in a prospective cohort of 28 patients that we identified on the adult inpatient unit. As we're about to publish, Max says to me and George, we should have a name for this thing that we're going to publish. And we considered the catatonia rating scale as a name, or the Stony Brook rating scale. And we arrived at Bush-Francis, which I think was a good name, and it stuck. So this paper has been highly cited and increasingly escalating amounts of clinical and research interest in catatonia, which is reflected in the citations of this paper, which is approaching 1,000. And if you look in Google Scholar or PubMed, you see an escalating amount of publications related to ECT, the biology, the clinical care, the epidemiology, prevalence, et cetera. So our rating scale, we ended up with 23 items on it. And where did we get these items? Most of them actually come from Kalbaum's descriptions. Some of them are in Kalbaum's case histories, but he doesn't name them. An example would be ambitendency. Ambitendency is motor hesitancy. It's as if the patient is stuck doing and undoing a movement, and you're going to see an example of this on a video coming up. So most of these were historical from prior workers dating from Kalbaum and then later Kraepelin and other workers. So we arrived at 23 items, a selection of signs and symptoms of catatonia. And we wanted a number that was workable. So we ended up with 23 items, but also broad spectrum to look for subtypes of different phenomenology. So for example, an excited form of catatonia or a stuporous or retarded form of catatonia could be captured. And we wanted our rating scale to be useful for making a diagnosis as well as for rating severity in terms of treatment or other outcome kinds of studies. So in psychiatry, we make diagnoses by signs and symptoms being present. How many signs and symptoms will define a syndrome? So a priori, before we started collecting data, we wanted to capture mild cases. So we set a low bar, which was going to be 2 out of these first 14 items. So we were going to define a case in our research by 2 out of the first 14 to define a case present or absent to any severity would be caseness. And then severity would be taking all 23 items and rating them on a 3-point scale. And we operationalize what each of these things are. Most of these catatonic signs are observational. You see them by just observing the patient. For example, immobility, stupor, they don't move. posturing. They maintain an unusual or a mundane posture for extended periods of time. Grimacing, you could look at that as stereotype movements of the lower part of the face. And you'll see some examples of these things on the videos coming up. Some of them are elicited. That is to say, the examiner does something to elicit the sign. In the case of echopraxia and echolalia, the examiner makes some verbal statement or some movement, and the patient mimics the movements or the speech of the examiner or someone else in the room or even a person on the TV. That's echo phenomena. Echopraxia is they mimic the movements, and echolalia, they mimic the speech, and you'll see this on the video. Negativism is an active resistance to engagement. And a few of them are by physical exam. So for example, rigidity and waxy flexibility, these are two abnormalities of motor tone. So again, we were going to define caseness by at least two. Later research shows that in medical populations, for example, you should use a criterion of 4 signs as more specific in medical populations. The DSM-5, which is an improvement over the prior DSM series, the definition is similar to ours. It's 3 present out of a list of 12, and the items in the DSM-5 are in the asterisk. The DSM-5 leaves off rigidity and staring, which are 2 very common and often important catatonic signs. Here is that list of DSM-5 catatonic signs. Again, the DSM-5 wants 3 present out of 12. No severity is listed, and the definitions of them are not as good really as we have. So for example, the DSM-5 definition, stupor, not actively related to the environment, and negativism, no response or instructions to external stimuli. So I think these are not well defined and they overlap. So I think it's perfectly okay for most purposes to use the DSM diagnostic system, which would be 3 out of these 12. However, the definitions of the signs, I think, are better done on the Bush-Francis scale, which is operational for each sign. We also included a standardized assessment, an exam methodology of exam, a standardized way to examine the patient for catatonia. And it was designed to be done in 5 minutes to allow a rapid assessment of the patient, and a standardized way to improve reliability across examiners. And with the operational definitions of the signs and the operational definitions that we arrived at and the standardized exam, we get high inter-rater reliability. The inter-rater reliability kappa statistics are 0.7 and above for both diagnosis and severity. So it has good, the rating scale has good psychometric properties, and it's highly reproducible and sensitive to treatment change, which I'll show you shortly. So it's possible that some people in the audience have not seen catatonia. Because this presentation is going to be recorded and available to the public, I'm going to use publicly available videos. Some of them are real patients that are historical, but in the public domain. And some of them are possible patients who whose families posted videos online. So this first example is from the early 1930s, from the, I believe it was University of Minnesota. And the patient's on the right here, the doctor's on the left. It's an old grainy black and white video from the early 1930s. And the doctor here is Dr. William Bleckwen, who invented the first treatment of catatonia, which was a barbiturate, sodium amylbarbital, also known as sodium amytal. And what is being demonstrated here is a very classic but severe form of catatonia, the so-called stuporous or retarded form of catatonia. And you will see, I think I have narration on this video, pointing out the catatonic signs that are elicited from this brief video. So his arm remains in an upright posture where it was previously placed. And you can see that the examiner moves the limbs and they stay in unusual postures, which may persist for long periods of time. And notice how the whole body seems to be rigid. There's no fluidity at all to the man's posture. He may remain in this unusual rigid posture for extended periods of time. He's not talking to, he's the examiner. He also shows mutism, another catatonic sign. And he's blankly staring, not really engaging with the examiner, who is moving him around. We'll see a close-up of his face here. And you'll notice that he's blankly staring, he's mute, he doesn't engage with the examiner. So it's staring, mutism, withdrawal, rigidity, and catalepsy. Multiple catatonic signs that are all. So this form of a severe or gross manifestation of catatonia, we still see this today. This does happen. Fortunately, most patients are not as severely affected as this, but some are. And so this has a historical resonance that we still see this. So catatonia also can occur in a hyperactive form or a more physically active form. This would be the stupors or retarded or inactive form of catatonia, perhaps more common than the excited or hyperactive form. So I'll show you a couple of examples of the more hyperactive form. Again, these are old historical videos that are in the public domain. They're actually available from the National Institute of Mental Health. So here's a man who's going to have repetitious movements. And there are a couple different kinds of repetitious movements that you can see in catatonia in the hyperactive form. Stereotypies and mannerisms. What is the difference? Mannerisms, and sometimes it can be difficult to tell. Mannerisms are repeated movements like stereotypies. They often involve parts of the body used for communication, such as the hands and face. And they often occur in a sequence. Sometimes there are caricatures of using the hands or face for communication. So you'll see they have a ritualistic kind of element to it. So mannerisms seem odd the first time you see them, as opposed to stereotypies, which are not in themselves abnormal, just the frequency. So for example, rocking. So this man is going to show repetitious manneristic movements. So he's got a sequence of touching his lapel, touching his coat, and touching his tie. He also seems to be moving a piece of paper back and forth between his hands. If you look closely, he's also got grimacing, which is dyskinetic-like movements of the lower part of the face and tongue and the lips. And he's overall hyperactive. See those movements of the face. This was all done in the pre-neuroleptic era. If we saw this today, those movements in the face, we would think of tardive dyskinesia. Here's another example of echopraxia. Again, echopraxia is the patient, without being bidden to do so, mimics the movements or speech of the examiner. So this patient is sitting next to the doctor on a bench outdoors, and she mimics the posture of how the doctor is sitting, but she also mimics his movements without being bidden to do so. So you see she's sitting with the same posture with a crossed leg. She had her hand to her chin as he did. He makes a movement. She repeats it without being bidden to do so. She does this imperfectly. He taps his leg. She does so perhaps a little overly vigorously. And that's an example of echopraxia, which is one of the features of the hyperactive form of catatonia. Now, catatonia is being increasingly recognized, thankfully, in populations with developmental disorders, and treatments are being applied. We don't know a lot as of yet about how well a population with developmental disorders responds to treatments for catatonia, because their treatment is often their catatonia is often very chronic, and chronicity of catatonia is one factor that reduces the treatment response. So these are I'm going to show 3 video segments from the YouTube. These were posted by families saying, this is our child with autism. So I can't make a diagnosis of these children and youth. But what I can say is, should a person of their age appear in the clinic and show these kinds of movements, here are some catatonic signs that could be considered. So it's in that spirit that I'm describing what we might be seeing on these real people whose families posted videos on YouTube. So this young man, you're going to see a hyperactive form of catatonia, of what possible catatonia. where he's repetitiously moving his right arm and also his neck, but his left arm remains still in a posture. So he has what could be stereotyped movements of his right arm and head and neck, while the left hand remains in a posture. So were he in the clinic, you might say this is posturing and stereotypy, an overall level of hyperactivity, a mild form of excitement. Okay, he's now going to use the silverware. He's perfectly capable of using this hand, by the way, that showed those movements that are possibly stereotypies. He's going to pick up some food and bring it to his mouth, and you'll see he gets stuck in the middle of doing that, which if he were in the clinic and being assessed might be ambitendency, which is this ability, this phenomenon of being motorically stuck in the middle of doing something. So were he a patient in the clinic and showing similar behaviors, we might say that the left hand had posturing, the right hand had stereotypies, as did the neck, and also ambitendency, and that he's overall hyperactive with a mild form of excitement. Here's another young person. Again, same thing, family posted a video online. Were this young person in the clinic and being assessed and showed these kinds of behaviors, possible catatonic signs are listed here, which include withdrawal, stereotypy, mannerisms, and mutism. So she's going to, she has a caregiver that is escorting her out of the house and onto the sidewalk. And you will see that she shows what could be catatonic signs were she in the clinic and being assessed. So there's a possible posturing of the right arm. She also shows no interaction with this caregiver, so that would be withdrawal. And mutism, she doesn't talk. And once she gets outside, she turns in a circle repeatedly and rubs her hands together repeatedly. And again, seems to have no interaction with the caregiver. So possible catatonic signs where this person in the clinic and showing such behaviors are listed here, which include withdrawal, stereotypies, mannerisms, and posturing. Last example that I'll use is a apparently more severely affected young person. Again, same thing, family posted video online. This is our child with autism. And he's wearing protective gear, presumably because he has self-injurious behavior, which can be a form of catatonic stereotypy identified in developmentally disordered population. So he's got repeated movements of the fingers, which I would call stereotypies. He's also in constant motion, a mild form of excitement. He's mute, and he has some stereotype movements as well. So were this young person in the clinic and showing these kinds of behaviors, these would be the catatonic signs that could be considered possible. He might have staring, it's hard to tell. So I've been advocating, and others as well, to have better recognition of catatonia in populations with developmental disorders, because these can be very disabling and disturbing, and also can be treatable, in some cases at least. More videos are on the website. So is catatonia a historical relic, or is this something we still see? And the DSM-5 apparently thought the catatonia wasn't worth having a diagnostic code for. So the preliminary committee dealing with catatonia, which was a psychosis committee, didn't think they needed a catatonia diagnostic code in the DSM-5. And so we wrote this article to try to influence them that catatonia is real and does exist and is prominent when it does exist. And this was a summary of numerous prospective assessments, prospective screenings of adult psychiatric patients on an hospital setting. So these would be prospective studies on catatonia incidence in adult psychiatric hospitals. The third one here is our study. Most of the studies since have used our rating scale. And various numbers of patients being studied. And it's about 9%, that ballpark, of people who are adults in a psychiatric hospital that will show catatonic syndrome. And important to note that two common signs of catatonia, which is mutism, they don't speak; withdrawal, they don't interact with the environment; negativism, they actively resist attempts to engage them, are very common. More than half the patients have these things. So the argument we made in this paper, attempting to influence the DSM-5 committee, was that catatonia does exist, and that when they're in the hospital, they often don't speak and often don't engage in behaviors which would obviate ability to make diagnoses on them, because they're not engaging in behaviors and they're also not speaking. So that at least provisionally, we should have a diagnosis code for catatonia that would guide treatment and work, at least initial treatment and workup. So I don't know whether that was persuasive or not, but the DSM-5 does have a code for catatonia, which is the presence of at least 3 on that list, as noted earlier. And that code can be applied and added to other mood or psychotic disorders. There is a way to have catatonia not otherwise specified as a provisional diagnosis. And it can also be attached to medical diagnoses. So actually the DSM-5 was a big advance. So in our study, as I mentioned, we prospectively identified a cohort of 28 patients from screening on our inpatient unit, adult inpatient psychiatric unit. And we studied the characteristics of catatonia and also the response to treatment. So there were some case reports about lorazepam being useful for catatonia, but we wanted to be systematic and quantitative in assessing how good this was as a treatment. So we constructed a lorazepam treatment trial over 5 days. And we attempted to give intravenous lorazepam, 2 milligrams over 5 minutes at 5-minute intervals. That is to say, baseline, 1 dose of 1 milligram, and then 5 minutes later, another dose with ratings in between. And we continued the trial for up to 5 days. In retrospect, this is underdosing, but we had a limit of 8 milligrams a day by any route. And we did daily ratings of catatonia scores on them. Success was they no longer met criteria. Failure was they remained catatonic or they got worse in terms of their clinical status or becoming more agitated. So this was the result from the intravenous treatment of with lorazepam for catatonia. And what's shown here is the full score, 23 items, each item rated on 3-point scale, 3-point item, 3 points per item. So 23 items times 3 is 69. The maximum score is 69. Most patients who are in a hospital, medical floor, psychiatric floor, are going to be somewhere between 15 and 25. That's a pretty severe case of catatonia, as were these. So this was their baseline catatonia score. And after 1 milligram, 5 minutes, score was reduced. And after a second milligram, 2 milligrams total, 10 minutes total time, the total catatonia score was about a third of what it had been before. So there's often a very dramatic initial response to lorazepam when given IV or IM, or even sometimes oral. And this can be used as confirmation of a suspected diagnosis of catatonia. So this was in our original paper, and this has now become known as the lorazepam challenge test, used for diagnostic clarity and diagnostic confirmation. So carrying out the treatment trial over 5 days, there were responders, which was about 2/3 of the patients responded, and there were failures. What were the predictors? Age and catatonia score and basic demographics do not, and diagnosis do not predict response. This has been confirmed since. A very severe case of catatonia or a milder case can respond to lorazepam. What is a predictor is duration of catatonia. Not surprisingly, the longer someone has had something, the more resistant it might be to treatment, and that was confirmed and has been confirmed by other papers since. And the initial response on the first day. So if there is a partial response to the first few doses of lorazepam, that usually predicts a better outcome than no response at all. And at least in this study, which was in retrospect underdosing, dose didn't seem to be a predictor. In fact, the failures had a higher dose. I say the dose was low in this study because we've learned subsequently that some patients with catatonia will respond to much higher doses in the dose range of 20 to even 30 milligrams per day. Obviously not on the first day, but titrated up. And those scenarios are where ECT is not available or not feasible for one reason or another. So the patients who failed lorazepam did respond to ECT, usually quite promptly. So these are people who had the 5-day trial of lorazepam and failed. Now they're getting bilateral ECT. And we stopped the lorazepam. In retrospect, a later study that we did showed that low doses of lorazepam are synergistic with ECT. So nowadays we keep a little bit of lorazepam going with ECT. And in general, ECT is highly effective for catatonia, whether it's medication resistant or not. And if the ECT doesn't seem to be effective, questions about how the ECT was done, that is to say, was it a robust form of ECT with adequate monitoring and induction of fully therapeutic seizures? So the response rate is not quite 100%, but very close to for catatonia being treated with ECT. There doesn't seem to be a placebo response, but there's only actually one placebo-controlled trial of catatonia, and that was with the barbiturates done by Vaughan McCall in the 1980s. And it was a short-term trial, a 10-minute trial, just like our RV challenge was. And there was no placebo response, and the response to the barbiturates was similar. There hasn't been a placebo-controlled trial of ECT or of lorazepam for catatonia. The very first patients who were treated with convulsive therapies back in the early 1930s happened to be catatonic, and they responded well. And if they hadn't been, we probably wouldn't have convulsive therapy. Neuroleptics seem to make catatonia worse. There are reports of patients with catatonia receiving, especially the older high-potency neuroleptics, converting into a malignant form of catatonia that is also known as Neuroleptic Malignant Syndrome. Variety of miscellaneous agents. The most well-established treatment for medicines would be lorazepam. It does seem to be more effective than other benzodiazepines, although a diazepam is perhaps a alternative in some cases. There's studies on other GABA A agonists, such as that lorazepam is as well, such as zolpidem. This tends to have a short-term response that fades over time. There's some evidence from case series and case reports about NMDA blockers, including memantine, and this might be useful in consultation liaison settings where delirium and catatonia coexist, which is what I'll be talking about shortly. And there's conflicting evidence about atypical antipsychotics. There's no real well-done study on antipsychotics and catatonia, specifically addressing the question of response to catatonia by these agents. So catatonia, if it's severe and persistent, has a lot of medical complications. And most of these are the complications of the severe form of retarded or stuporous catatonia. They tend to be the similar complications that you might see to someone else who is kind of lying in bed and bedbound and not moving. Aspiration pneumonia, renal failure, sepsis from skin breakdown, bed sores, etc., pulmonary embolism, rhabdomyolysis, respiratory failure. These are less common nowadays because catatonia is more recognized and treatment interventions are made, and also efforts made to reduce the incidence of these things, even if treatment can't be started quickly. So for example, muscle breakdown and pulmonary embolism by keeping the patient well hydrated and mobile, if at all possible. So we worked several studies related to catatonia. First, just establishing, can this be just viewed as a valid syndrome? Does it have the characteristics of a syndrome? That is to say, a collection of signs and symptoms that comes on together, persists together, and responds to treatment together. And that basically is true. Responds to biological treatments. Prevalence of phenomenology, treatment, subtypes, discrimination from other motor syndromes. We used a very elderly population there who average age was over 70, who had been in a psychiatric hospital for 30 plus years. It was a cohort in the state hospital in Long Island. And we studied them because they had a high rate of other motor disorders, things like tardive dyskinesia and Parkinson's, drug-induced or spontaneous. And the question was, can we tell catatonia from these other motor syndromes? And the short answer is yes. Looking at neuroleptic malignant syndrome as a drug-induced form of malignant catatonia. Malignant catatonia means catatonia associated with severe autonomic symptoms, things like fever, diaphoresis, hypertension, tachycardia, or labile vitals. And this last topic, which has intrigued me in the past few years and what I'll finish with today, is the delirium with catatonic features. And I'll talk a little about that because that's very important and a new area of research in recent years. So when I was in New York, I was an inpatient psychiatrist and a consultation liaison wannabe. I would occasionally cover the consultation service. And I think my home is probably better in consultation liaison. I'm going to the consultation liaison meeting, and I have been going for many years, where I'll be presenting on catatonia this year. And one time I was covering the consultation liaison service, and the geriatric fellow, Antonio Lopez Canino, said, "I'm seeing some patients here delirious that seem to have delirium and catatonia both." And I kind of had some awareness that this occurred. But in that month alone, we observed 3 patients that met criteria for delirium and catatonia, the DSM criteria. I'll explain what those were shortly. And so I began to wonder that maybe there is a form of delirium with catatonia. There's delirium with and without agitation. There's delirium with and without psychosis. Is there delirium with and without catatonia? And does it have some implication for treatment or outcomes? Or is it a prognostic factor, a better or worse outcome from delirium? So I thought it should be identified, named, and studied. So in this paper, we described the 3 cases we had, and we did a literature search and found 13 other cases. Most of these other cases were a delirium with catatonic features associated with benzodiazepine withdrawal. And some of them had treatment by replacement of the benzodiazepine, where both the delirium and the catatonia got better. So in the literature on delirium, there are attempts to describe the phenomenology of delirium in terms of motor symptoms. And so various authors have described a hyperactive form of delirium and a hypoactive form of delirium, or excited, retarded, hypoactive, hyperactive forms. And there was some evidence in the literature about different biochemical abnormalities. For example, metabolite of melatonin seemed to be different between hypoactive and hyperactive. And there was some evidence of differential response to treatment. So it looked like the phenomenology, maybe the biology and response to treatment were different between hyperactive and hypoactive forms of delirium. And when we look closer at how these different delirium researchers described the hypoactive form of delirium in particular, it looked like they were talking about patients who were catatonic. So here's, at the time, there were 5 published studies describing methodology and prevalence of catatonia, of hypoactive delirium defined in different ways. This is Dr. Wes Ellie at Vanderbilt, who's the inventor of the CAM, the confusion assessment method of assessing catatonia. Decreased level of motor activity, staring, staying in one position, moving very slowly. So when we consider how this might map to catatonia, immobility, staring, posturing. Here's a Memorial Delirium Assessment Scale. This is Dr. Breitbart at Sloan Kettering and colleagues. Reduced or slowed movements, rarely moves or speaks, is catatonic, actually uses that language. So these research definitions of hypoactive delirium seem to map onto catatonic signs. And so what we found was in this literature review of 3 prospective and 13 literature cases, 16 total, is that they had a typical presentation of catatonia, of the retarded form of catatonia. They had mutism, withdrawal, posturing at high frequencies out of the 16 patients. So they looked just like the psychiatric patients with catatonia, grossly speaking. So you might wonder, well, how is it possible to assess for delirium in a patient who's catatonic? Because they often don't speak or speak very minimally. Well, it turns out you don't actually need to speak. So here's the DSM-4 criteria for delirium. And these patients in our study met DSM-4 criteria for catatonia and delirium concurrently. Disturbance of consciousness, change in cognition or development of perceptual disturbance, develops over a short period of time, and there's a biological cause. Doesn't say anything about talking. DSM-5, disturbance in attention or reduced awareness, short period of time, and additional disturbance in cognition, which could be visual, spatial, or perception. In other words, they don't necessarily need to talk. So they could be quite mute or totally mute and still be potentially diagnosed. It can be challenging, but they can be diagnosed with delirium, and people have done it. So I tried for years to get our consultation service in New York when I was there to do a prospective study to no avail. But Sandeep Grover in India was inspired by that paper and did do the study I wanted to do. So he and his group are at a teaching hospital in India. They looked at 205 consecutive consultation referrals for delirium. They confirmed the delirium using a systematic rating scale. This is the Trapaz delirium scale. So they met DSM-5 and research criteria for delirium. And they assessed for catatonia using our rating scale, grading catatonia 2 out of 14, which is a lower bar, and 3 out of 12 on the DSM, which is a higher bar. So they were prospectively identified and confirmed by research instruments as having delirium and having catatonia. And among this population confirmed to have delirium, 32% met our criteria and 13% met DSM-5 criteria. And the severity of the delirium measured on this scale and the severity of catatonia measured on this scale correlated. That is to say, the more severe the delirium, the more severe the catatonia. And it was correlated with a hypoactive form of delirium. So this was really the first systematic confirmation that delirium and catatonia can coexist, which the DSM-5 says is not to be allowed, although data shows it does happen. Shortly after this, Jo Ellen Wilson at Vanderbilt, I met her at one of the psychosomatic conferences, and she was also inspired by that paper that we did a few years prior. And she's at Vanderbilt where Dr. Ellie is. She had done residency and also as consultation fellowship. And she was interested in looking more closely at delirium and catatonia. Dr. Ellie does large, federally funded multi-center trials of delirium outcomes. And so what she did was attach catatonia ratings to one of these delirium outcome studies. So these were patients, middle-aged and older, entering an ICU who were not delirious and not catatonic on entry to the ICU, primarily with sepsis and respiratory disorders. And in this delirium outcome study, they were getting physiological measures and rating scales. Some of them were also getting treatments. And she did blinded to the delirium category, catatonia assessments on them, she and her colleagues. And I got myself to be a co-author with her as an outside collaborator. This was the first paper, and it was published in a critical care journal a few years ago. And what we found is, not surprisingly, in this middle-aged and elderly population, there was a high rate of delirium, 40-some%. But she also found, and this is DSM-5 criteria for both delirium and catatonia. Delirium was by the CAM method, but confirmed by DSM. 30% had coexisting delirium and catatonia during their ICU stay. Only a few had catatonia alone. The presence of catatonia, preliminary analysis shows it's a predictor of a worse outcome. That's still under study. So it might be a marker of a more severe illness or a more severe outcome. Now, is this something that is more widely occurring? And I've started to look now at larger database, and this is the Trinetics database. This is a large United States national database, has 213 million unique individuals in it, including VA, Medicare, Medicaid, many health systems participate. And the question was, can we use this national database with a large sample to find out, do delirium and catatonia coexist, and maybe find out what some of the characteristics and outcomes are. So this is sort of the first attempt, which I only looked at in the past couple of weeks. So the and you can search ICT codes, you can search procedures, you can search labs and medications, and you can search them with a time link, which is important for this. So there's a couple different ICD codes used for delirium. One is ICD F05, and one is R41.0. So this one has 734,000 unique people who have diagnosed with delirium and 1.7 million who've been diagnosed with confusion. And if you read the descriptions, it sounds like delirium, and delirium is actually mentioned. This one's probably used more often. So if we say, well, how many people had one or the other of these? It's 2.3 million nationwide at any time in their life. Now we can add a time constant to see where they also diagnosed with catatonia. So of those 2.3 million people, how many of them also had catatonia diagnosis plus or minus 1 day from also getting a delirium diagnosis. Now, delirium lasts more than 1 day. So the inference would be that catatonia was coexistent with the delirium. And there are 1,531 such people in the database. Now I'm looking, you can get additional data on them in terms of outcome and treatment and labs. So I'm looking into that. But it does imply that there are, at least in this sample, there are going to be people from a much larger national database who have coexisting catatonia and delirium in terms of what was their treatment, what was their outcome. Their age is on the order of average age of 70. I do know that so far. And their demographics is about 2/3 female, 1/3 male. What about treatment? So when catatonia and delirium coexist, do we know anything about treatment? Because we don't normally think about giving benzodiazepines to people who are delirious because it tends to make it worse. And we don't normally think about giving high-potency antipsychotics to people who have catatonia. It tends to make it worse. And that tends to be something that we use in delirium. So the treatments are sort of antagonistic. This was a study done by Joey Cooper and his colleagues when they were at the University of Chicago. And they were addressing catatonia in the medical floors. So they were able to do searches using the electronic record to identify people who were catatonic and maybe not recognized to be catatonic at the time by searching for text words in the progress notes and lab reports and x-rays. And what they found was they identified 54 people in the medical surgical population of the hospital, not psychiatric, who met DSM-5 criteria for catatonia, which is 3 out of 12 signs. Of those 54, 29 had apparent delirium. And it turns out that many of those patients got treatment with lorazepam. Turns out 29 got lorazepam, not the same 29. So of the 29 out of the 54 who got lorazepam, this is in the leftmost bar here, a leftmost vertical graph, there's 29 subjects here, 29 patients. Of those 29 who were the 54 out of 54 who had catatonia, turns out 29 got lorazepam. And of them, 83% responded, which is what you typically see with lorazepam. Looking on the far right, the last 2 bars. So these are now, again, those same 29 patients who got lorazepam trials out of the 54, now categorized as to whether they had no delirium or whether they had delirium. And they were treated with lorazepam. Somewhere between 71 and 100% got better. So the ones who had delirium, 71% got better in terms of their delirium and catatonia both, and 100% of the ones who did not have delirium. This is in terms of catatonia, excuse me. So really not much detail about how the treatment was done or over what period of time. And this was a retrospective chart review, but it's a hint at least that possibly when delirium and catatonia coexist, that at least some of them might respond to, their catatonia might respond to lorazepam. As I mentioned earlier, NMDA antagonists there's some case literature about them perhaps helping catatonia. We had a recent case of a person who had some cognitive dysfunction and also was catatonic. We weren't able to do ECT because of severe carotid stenosis. And we gave that woman, a woman in her 60s, as I recall, memantine, and her catatonia improved, and so did her cognition. And turns out that in the case literature about memantine, case reports and case series about memantine treating catatonia, buried within those case reports, in some of them at least, is the fact that the cognition also got better. So in the setting of delirium and catatonia, where there's cognitive disturbance and catatonia, memantine might be an option to consider for treatment of coexisting delirium and catatonia. So let me conclude with the premise that I hope to persuade you that catatonia is a distinct syndrome. It does really exist and has prevalence in different populations. It's associated with morbidity of severe and untreated. Highly responsive to treatment if recognized and diagnosed. About 2/3 or so will respond to benzodiazepines. The response to ECT is 95 to 90 to 100%. Catatonia and delirium may coexist, despite the fact that the DSM doesn't allow those two to be diagnosed together. The evidence is very clear that they both exist together. We don't know about the treatment or other outcome implications. So is catatonia with delirium, there's preliminary evidence from Joel and Wilson that it's a bad predictor of more morbidity, but we don't know that systematically as of yet. So is delirium with catatonia a worse form or a better form of delirium, so to speak, without catatonia? So we don't know about the treatment implications. We can consider a short-term lorazepam trial. Patients with delirium in the ICU, for example, often get lorazepam before we get there to tell them not to do it. I would avoid neuroleptics. We would consider other agents such as memantine. So let me stop there, and I hope to have sufficient time for some discussion and questions.
Thank you, Dr. Francis. Really appreciate that. There are a couple of questions in the chat that I'd just like to ask. So one is, how would you differentiate the stereotypies associated with autism versus those that might be a symptom of catatonia?
So the short answer is, what else does it travel with? So people with schizophrenia sometimes, and people with developmental disorders may have stereotypies and nothing else. So do they have, what else is traveling with it? So catatonia is a syndrome, it's a cluster of things, and look more closely for other signs of catatonia. So we do see people occasionally who just have stereotypies and nothing else. Both adults and children with autism and also without autism. And sometimes that responds to the treatments for catatonia. But the short answer is look for something else.
Great. And then next question, when a patient on inpatient psychiatric service presents with catatonia, should a medical and psychiatric differential diagnosis be completed or documented?
It depends on the history of the patient. So we have patients, and I'm sure you do, who show up every now and then catatonic, and they had an extensive workup on the last admission. And I probably would defer that unless there was something from the exam or basic labs. So I probably wouldn't do brain imaging or EEG or such kinds of tests. So it depends on the history. If it's brand new onset catatonia and a patient you know nothing about, they do deserve a clinical workup, and that might include brain imaging, it might include an EEG, might even include a lumbar puncture. But I would also point out that somebody who has epilepsy and presents with catatonia, somebody who has a brain tumor and presents with catatonia, somebody who has encephalitis and presents with catatonia, you're not very likely to kill them with 1 milligram or 2 of lorazepam, but you might find out that they improve. So again, depending upon the clinical context, you might initiate treatment even though a workup is in progress.
Super. And let me go to the folks with their hands raised. Dr. Bustillo.
Thank you. I think you made an excellent point on the importance of recognizing catatonia and treating catatonia and following up patients. You have influenced the field really tremendously in that regard. My question is, yeah,
I'm still trying to do
and my question is really, what's the best evidence that you're aware of that catatonia is a separate syndrome? Because most of us clinicians, we see catatonia and we treat it as you've suggested, and we say, well, I mean, look at the whole history. This patient has schizophrenia. They need to be treated for schizophrenia. Yeah. Eventually we will withdraw the benzodiazepines, but we will keep him on an antipsychotic. This person has bipolar disorder. We'll treat him with lithium, but we will withdraw the. So I mean, those are cases in which, not to minimize the importance of catatonia or the significance, but those are cases in which we sort of explain the catatonia as part of a larger syndrome. So my question again is, what is the best evidence that there is catatonia that is an independent syndrome?
Well, you do see people who have, they're not a lot, but we do see people who have catatonia and do not seem to have a mood or a psychotic disorder or a definable metabolic or medical or neurological condition. So we do see catatonia not otherwise specified, or quote, pure catatonia. But I would point out that catatonia is in a psychiatric population, it's more associated with mood disorders, particularly bipolar, compared to schizophrenia. In a medical context, It's associated with neurological and certain metabolic illnesses. And the presence of catatonia, irrespective of what else it travels with, implies a response to these very specific treatments.
Sure. So again, I'm sorry. So the best evidence that there is, it's really anecdotal that you can say, oh, I've seen them too, patients that have catatonia and don't seem to have anything else. But is there any systematic evidence that supports that there is such an independent syndrome as catatonia?
Well, only that studies find it. So for example, in our cohort of 28, we had 2 that didn't seem to have any other diagnosis.
And those patients were followed long-term to ascertain that indeed.
One of them several years.
Okay, thank you.
But the catatonia freestanding, so to speak, is probably uncommon because it was more common in Kalbaum's day. He didn't have CAT scan. So it probably does exist, but again, it's a syndromic presentation of other things most commonly. This you might, if you want to use that language.
Great, and Dr. Shed.
Yeah, my question is related because I've seen this pure catatonia in my training and really tried to find evidence of like a previous mood disorder. Mm-hmm. And I remember just feeling conflicted because I didn't know how to, we of course treated the patient with ECT and he responded, but we didn't know how to prevent future episodes.
Well, there are diagnostic systems that we don't use in America. And they're popular in a couple of universities in Germany. And they derive from Wernicke and his pupil Kleist and Kleist's pupil Leonard. And in that system of diagnosis, there's 8 types of catatonia, one of which is called periodic catatonia. What is that? It's people who just have catatonia and nothing else, and they've been followed for years. We don't see it in America for some reason. It's uncommon. You know, everybody who's working in catatonia or who's in an academic center will say, yeah, we've had a couple people that they were catatonic and couldn't find anything else wrong with them, and maybe they were lost to follow-up, or they showed up a couple years later and they're catatonic again. So it's probably here and there. Such patients do exist. They were recognized by those German workers, and they're in that diagnostic system as periodic catatonia. A father and son team of Norwegian psychiatrists studied them and said that the treatment was thyroid hormone. And that you can look those up, Jessing, G-J-E-S-S-I-N-G.
Super. Are there any other questions for Dr. Francis? Your burning catatonia questions that you've been dying to ask. Now's the time.
So for neurodevelopmental disorders, it seems that it can be more persistent catatonia.
Yes.
Does this mean that we need to treat patients chronically with benzodiazepines or maintenance ECT, or what would be your approach in those scenarios?
Well, it depends how severe it is and how it responds to treatment. So, I mean, I think so in the examples I showed, again, were those people in the clinic and showed those phenomena, you would say that these young people are severely affected and disturbed in their functioning by those apparent catatonic signs. So it's something that warrants treatment, let's put it that way. So first of all, do they have it? And secondly, is it sufficiently disturbing to their functionality? So that would be the first question. Recognize it and say, is it disturbing their function? So some people have chronic mannerisms or stereotypies. They just have that. They live with it. So I'm not really talking about that. I'm talking about people who have this syndromic presentation. And those examples on the video were illustrative of that. So they warrant treatment, and how aggressive the treatment can be. You'd consider benzodiazepines to start. And the longer they've had something, the less likely it is to respond, or the less robust the response might be. But nevertheless, I think I would try a response. We, and I'm sure you and your ECT shop are probably treating some young people or middle-aged people even with developmental disorders who have catatonic presentations and are probably on maintenance ECT. We have several. We published a few actually recently, and they often do well with maintenance ECT and are often dramatically changed in their lives, I might add. And the person who has written the most about that is Lee Wachtel at the Kennedy Krieger, which is attached to Johns Hopkins in Baltimore, WACHTEL. She published a case series a couple of years ago of 20-some such people who are extremely disabled. These are people who are in behavioral unit on 4-to-1 holds who get better with ECT. Some of them had catatonic excitement. Some of them were gouging their eyes out and self-injurious behaviors framed as stereotypies for catatonia. So there can be dramatic improvements from recognizing it and treating it. So that's why I'm on a mission to get better awareness. Now, maybe they won't have as robust a response to catatonia that you see in mood disorder, which tends to be 100% responsive. But suppose it's 10%, is it still worth doing? Yes. Suppose it's 5%, still worth doing. Still worth trying to identify the people with developmental disorders who have catatonic presentations. Even if a small percent respond to treatment, it can be a tremendously positive impact on their function in life.
All right, we're unfortunately at the top of the hour, past the top of the hour, and I just want to say, Dr. Francis, can you hang out for a few more minutes?
Yeah,
Just to, last remaining questions. Dr. Gonzalez, you have your hand up.
Yes, I was wondering, for folks with developmental disorders, can the rating scales, or are the rating scales relatively reliable and consistent, or do we have to modify it when working with these folks and assessing them?
I think you can use it. There is a pediatric variation of the Bush-Francis, which has been published, if you look it up. I don't remember, actually can't remember who the authors are, but they did a pediatric modification of it. But we found it useful. And the interesting thing is that catatonia is often very heterogeneous, and there's a mismatch between the frequency and severity. So someone may have one particular catatonic sign, mannerisms and stereotypies, that's very dominating the clinical picture and highly disabling, but they don't have anything, they don't have much else. So we saw that in our original research, that it was very heterogeneous, that like you see on that video, the woman sitting on the bench with her doctor, she does nothing except mimic him. So she has a gross form of echopraxia, but she may not have other things. But look how disturbing that must be to her function, that she's mimicking what she sees around her.
Excellent. No, I think that's good information, and I'll be looking up the Wachtel. Is that pronounced it?
Wachtel. And then there's a pediatric version of the Bush-Francis.
Oh, excellent. Thank you.
Not by her, by someone else.
Okay.
And it looks like there's a question in the chat. Sorry. Yeah. Any tips for treating patients with primary psychotic disorders such as schizophrenia, specifically balancing treatment of psychotic symptoms with an antipsychotic, but without worsening catatonia?
Try to hold off on the antipsychotic as long as possible. Keep the benzodiazepine going. And then there's some evidence that a blood test, which is serum iron, might be predictive of adverse reaction to neuroleptics, conversion to a malignant form, or worsening of the catatonia. So do a serum iron and closely monitor the vitals and look for extrapyramidal or worsening catatonia. So the scenario happens all the time. Do we relieve the catatonia? They're uncatatonic now. However, they're psychotic. What do we do? So keep the benzodiazepine going, wait as long as you can, and then probably use an atypical. There's actually a small study of risperidone, very small study, 8 subjects.
Okay. All right. Any more questions? All right. Well,
I can't see the chat, so if there's something in the chat that you want me to answer, I can't see it.
Yeah, I think we dealt with everything in the chat, and a question that I always come up with our practitioners here is, so you treat someone with catatonia, their catatonia gets better, you discharge them from the inpatient psychiatric unit.
Yes.
How long should you continue benzos for?
You don't have to answer that question because the clinic will stop them.
But if,
So
but if you could-
you have this person finally better, or they're on 12 a day of lorazepam. You send them to the clinic. Clinic says, why is this person on 12 of lorazepam? And try to keep. So the answer, we ran a session at the APA on just this question. Catatonia is better, now what? And with the outpatient doctors from Columbia a year or two ago, workshop at the APA on this very question, that we finally got them better, but they're on pretty high doses of lorazepam. The clinic won't keep them going. And try to keep them in your own system.
Okay, so it sounds like you would keep them on the benzos for a significant period of time after discharge.
The catatonic population don't seem to develop a tolerance or an addictive pattern, in my experience. And I had people for 20 years on 3 milligrams. I mean, I think and when I talk to other people, they say the same thing. Yes, I've had people on chronic low-dose benzodiazepines. They don't get tolerant. Their catatonia stays in abeyance, and they're not abusing it. And it's peculiar. I know how to understand that, because the other things that benzodiazepines treat, that's not true for.
Mhm.
It's a mystery. It's
Super.
a mystery demanding someone to investigate.
Got it.
I
Wonderful.
have a quick question. There seems to be this misconception that poor nutritional intake and poor fluid intake is specific for catatonia. So if they're eating and drinking, they don't have catatonia. Can you respond to that? Do you hear that elsewhere, or is that just here in New Mexico?
So catatonia fluctuates. And there's old literature that the hospital's on fire, they get up and walk out. Same for true for Parkinson's, by the way. So I personally have seen this, and it's in the literature. There are people who will stand in the hallway posturing or lie on the floor posturing all day long. When the nurse calls lunch, they walk down and have lunch, come back, and then resume their posture. I've seen this myself several times. Some of you have probably seen the same thing. And Kalbaum said it can fluctuate. So the nurses will say, quote, it's behavioral, unquote, because it fluctuates. But they don't say that about delirium. So when the patient with delirium has a lucid period, usually in the morning, and they're confused at night, they don't say, oh, it's behavioral. They say, oh, that's the variation of delirium. They know that. But with catatonia that fluctuates, it must be behavioral, because at sometimes he's engageable or does stuff, and other times he's withdrawn and mute and posturing. So it's a phenomenon that does exist and requires education from the staff. Now, there may be people who are malingerers or manipulative that mimic catatonia. That's possible. But catatonia itself, Kalbaum said, is correct. You see it today, it fluctuates. Sometimes, well, unfortunately, it doesn't fluctuate enough, because people die of this. There are people who have stuporous retarded catatonia. It's not recognized. They're lying in bed. They get a blood clot or sepsis from lung aspiration. And even today, the morbidities and even mortality from catatonia is not zero, even with better recognition and hydration, movement, more aggressive treatment. Still, there's morbidity and mortality from catatonia.
Super. Well, we've kept you an extra 10 minutes, and I really appreciate it. So thank you so much for your presentation, Dr. Francis, for lending us your expertise for this hour plus. And
My pleasure.
yeah, it's been wonderful for us. Thanks again.